So good morning and a very warm welcome again to the CMHS roundtable seminars. So we had a few roundtable seminars in past, one on geriatrics, one on violence against doctors. So when the last panel discussion was happening on violence against doctor, one thing which came up very strongly from all the stakeholders was the role of doctor-patient communication, and two important aspects which were discussed was all the medico-legal cases which happen against doctors. One of the most prime causes is lack of good doctor-patient communication background. Even if we take violence against doctor, one of the most important causes is the issues related to doctor-patient communication. So that then we thought that we should have a roundtable multi-stakeholder discussion on this topic of doctor-patient interaction or doctor-patient communication, which forms the basis of doctor-patient relationship in long term. And that's how the conceptualization of this roundtable seminar was decided. Professor Vaibhavi and Professor Devasmita and myself, we together sat and we thought which stakeholders we should call. Given the lack of time, there are many stakeholders, but how can we start the discussion at least so that we can take it forward from here. So at that time we had thought that we should involve around 7 to 8 stakeholders initially, but because of lack of time we have 4 major stakeholders, and all the stakeholders will give their perspective about the issues and challenges of doctor-patient communication. So I would like to invite the panelists. First we will begin with Ms. Jyoti. She is from the PLHIV network, people living with HIV positive in HIV and AIDS in Ahmedabad. There is a organization called GSNP Plus, Gujarat State Network of Positive People, with which we as CMHS have been working for last 3 or 4 years or so. And Jyoti Ben will represent the patient's perspective, what are the issues, difficulties, challenges which patients face when they visit hospitals, doctors. Then we have Dr. Garga Chatterjee. He is from ISI Kolkata. So he has he is a doctor himself, and then he has shifted to the academia in terms of statistics, and his perspective would be from the academician's point of view. His basic research happens in this area. He will highlight issues related to the challenges in communication which happen from the statistician academician point of view. Then we have Dr. Balaji. He is from Apollo Sugar, the chain of hospitals for diabetics, and interestingly we have been working with his clinic and his organization for past 2 years. And one of the interesting thing which I found in Dr. Balaji's clinic was, in general patients in India are very afraid of starting insulin. So injection lena padega, it will become a habit, shall I be able to leave it, all those questions come, and it's very difficult to convince them to go to insulin. And in his clinic I found very interesting thing that all the patients were very happy when they were on insulin, and their blood sugars were very well controlled. That is the perspective with which we started our research with Dr. Balaji's clinic, and he will be talking about how transparency and doctor-patient communication, the transparency and clarity in doctor-patient communication, the milestone building helps in actually patient compliance and patient adherence to therapy. Then we have Dr. Indu Arneja. She is the director of Indian Institute of Healthcare Communication, and she is a communication scholar. She has done his PhD in psychology, and she has taken many seminars, conducted many workshops on doctor-patient communication and doctor-patient relationship. Even in IIMA Ahmedabad, she has taken many lectures for the batches which come for the doctors batches which come for the management development programs. Okay, so let us begin with patient's perspective, and I hope we will get an overall view of this phenomenon from at least the 4 stakeholders perspective. We can, the purpose of this workshop would be to, once we have these perspective, we will develop a concept note and how to take it forward, what other stakeholders are involved, and how to comprehensively assess this phenomenon for the betterment of doctor-patient communication. That was our main purpose behind organizing this seminar. So we will start with the patient's perspective. Okay.
Good morning. ज्योति राउत, GSNP प्लस गुजरात HIV पॉजिटिव नेटवर्क। मैं यहाँ पे HIV पॉजिटिव पेशेंट की तरह से रिप्रेजेंटेटिव कर रही हूँ। हम अभी देखते हैं कि समाज में HIV का जो दर्जा है वो बहुत स्टिग्मा के रूप में देखा जा रहा है और हमें ज़्यादा करके ट्रीटमेंट की भी बहुत ज़रूरत पड़ती है, क्योंकि हमारी जो इम्यूनिटी पावर है वो बहुत कम हो जाती है। उसकी वजह से बार बार हमें हॉस्पिटलाइज होना पड़ता है, डॉक्टर की ट्रीटमेंट की सलाह की ज़रूरत होती है। अभी हम जो काम कर रहे हैं वो गुजरात के सारे ज़िलों में काम करते हैं और ऐसा नहीं है कि प्राइवेट हॉस्पिटल, हम गवर्नमेंट की जो फैसिलिटी है उसके साथ भी काम कर रहे हैं। तो मैं यहाँ पे जो मेरे कुछ अनुभव है, जो मैंने कुछ देखा है या मैंने खुद मतलब महसूस किया है, वो चीज़ें ही मैं शेयर करूँगी। प्राइवेट हॉस्पिटल में जब हम ट्रीटमेंट ले रहे हैं, ज़्यादा करके तो हम HIV पॉजिटिव लोगों को गवर्नमेंट के साथ ही लिंक करवाते हैं, क्योंकि वहाँ पे उसको इजीली दवा मिल जाती है, सारे रिपोर्ट फ्री में होते हैं। पर गवर्नमेंट में जो आज फैसिलिटी है, वो फैसिलिटी हम देखने जाए तो एक रिसर्च की तरह चल रही है। HIV पॉजिटिव लोगों के लिए जो ट्रीटमेंट मिल रही है वो मुझे नहीं लगता कि पूरी तरीके से सही तरीके से मिल रही है, क्योंकि उसे कोई छोटा इन्फेक्शन हो रहा है तो उसे तुरंत रिजल्ट नहीं मिलता है और उस लंबे समय तक वो जो छोटी चीज़ है वो बहुत बड़े स्वरूप में दिखाई देती है और उसके बाद उसकी ट्रीटमेंट चालू होती है। तो ये एक जो छोटी कमी है उसे हमें जल्दी तरह से पूरी करनी चाहिए, क्योंकि जो चीज़ हम कोई बीमारी बढ़ रही है उसके बाद कर रहे हैं तो क्यों ना हम उसे पहले से ही देखना शुरू कर दें। और उसके बाद है कि गवर्नमेंट हॉस्पिटल में आज भी बहुत सारी दवाइयाँ एकदम बल्क में दी जा रही है, जहाँ पे प्राइवेट में अगर मैं दवाई लेने जा रही हूँ अभी तो मुझे 3 या 4 गोली से रिकवरी आ रही है, गवर्नमेंट के उसके सामने ही 10-12 गोली, तो वो पेशेंट ऐसे ही कंटाल जाता है। एक तो पहले उसको इतना बड़ा बीमारी है, उसके साथ साथ इतनी सारी दवाइयाँ लेनी है। रिसेंटली मैं अभी मेरी बात करती हूँ, वो मुझे 8 महीने पहले और पूरी में बेड रेस्ट थी, मुझे मतलब पता नहीं क्या हो गया था, एकदम ऐसे ही ऑफिस से घर गई, 2 दिन मुझे नॉर्मल बुखार आया, तीसरे दिन मैं बेड से उठ ही नहीं पा रही थी। मैंने सिविल हॉस्पिटल में मेरी जो ट्रीटमेंट अभी चल रही है वही डॉक्टर से कंसल्ट किया, वहीं पे सारे रिपोर्ट करवाए, कुछ नहीं आ रहा था रिपोर्ट में, लेकिन 8 दिन तक मेरी हालत ऐसी हो गई कि मेरा खाना पीना सब छूट गया। उसके बाद मेरे फैमिली ने अच्छे से अच्छे HIV फिजिशियन को मिलना पसंद किया और अहमदाबाद में डॉक्टर मनोज सेवकानी से अपॉइंटमेंट ली, उनके साथ मेरी ट्रीटमेंट शुरू हुई। दूसरे ही दिन मुझे मेरा रिजल्ट डिक्लेयर हो गया कि मुझे माइंड में TB इन्फेक्शन है, उसकी वजह से मेरा जो फीवर है कम नहीं हो रहा है। 3-4 दिन तो मेरी कंडीशन ये थी कि मैं मेरे फैमिली के लोगों को नहीं पहचान रही थी, मेरी बेटी को तक नहीं पहचान रही थी, और वहाँ मुझे इमीडिएटली एडमिट कर दिया, मेरी ट्रीटमेंट शुरू हो गई और 2 दिन में तो मुझे थोड़ा बहुत रिकवरी भी आ गया। और इससे पहले मैंने जो 10 दिन तक जो ट्रीटमेंट ली थी सिविल हॉस्पिटल में, जो आज हम बोलते हैं कि हमारे यहाँ पे सबसे बड़ा हॉस्पिटल है, एशिया का नंबर 1 हॉस्पिटल है, पर मुझे आज भी यही सवाल होता है कि वहाँ पे क्यों मेरी वो ट्रीटमेंट नहीं हुई, या तो फिर क्या कमी रह गई वहाँ पे। जो रिपोर्ट मेरे हुए, रिपोर्ट की एक फाइल 8 दिन में वहाँ पे भी कंप्लीट भरी हुई थी और यहाँ पे भी एक फाइल पूरी बनी। यहाँ पे मैंने जो CT स्कैन, मेरा जो MRI हुआ उसके मैंने 25,000 रुपीज़ दिए प्राइवेट में। चलो मेरी फाइनेंशियल मतलब कंडीशन उस तरह की थी, या तो फिर नहीं भी होती तो हमने वो मैनेज कर ली, पर हर किसी के लिए ये पॉसिबल नहीं है। तो ये एक गैप है कि क्यों हम कोई भी बीमारी को जल्दी पकड़ नहीं पाते हैं। सिविल हॉस्पिटल में मेरी कंडीशन यहाँ तक आ गई थी कि डॉक्टरों ने ऐसा बोल दिया था शायद अब रिकवरी आना बहुत मुश्किल है, और धीरे धीरे मैंने जो ट्रीटमेंट शुरू की तो फिर मैंने क्या किया, सारे रिपोर्ट डायग्नोसिस सब क्लियर हो गया। फिर मैंने अब सोचा कि ये सारे रिपोर्ट के बेस पे मैं गवर्नमेंट में से ये डॉट्स स्टार्ट करूँगी। जब मैंने डॉट गवर्नमेंट में से स्टार्ट की तो ART और AKT दोनों का मेरे शरीर में इतना हैवी डोज हो गया, जो मेरी श्वास की जो गति थी इतनी बढ़ गई कि मैं एकदम एक दिन दोपहर में तो मेरा श्वास ही बंद हो गया। मुझे इमीडिएटली 108 में घर से लेके गए, फिर से मुझे प्राइवेट में एडमिट करवा दिया, वहाँ से फिर वापस वो स्टॉप कर दिया गवर्नमेंट ट्रीटमेंट। और अभी प्राइवेट की AKT, अभी भी मैं प्राइवेट की AKT ले रही हूँ। रोज़ सुबह 3 डोज लेती हूँ, रोज़ रात को 2 डोज। उसके अलावा गवर्नमेंट में मैं जो डोज लेती थी इतना हैवी डोज पड़ता था मुझे, तो मतलब पता नहीं किस तरह की दवाइयाँ आज हमें खिलाई जा रही है या क्या हमारे पे रिसर्च हो रहा है, क्योंकि जो दवाई प्राइवेट में मिल रही है उससे मुझे रिकवरी आ रही है और वही दवाई मैं गवर्नमेंट की ले रही हूँ तो मेरी हेल्थ में कोई ना कोई इश्यू हो रहा है। तो ये एक चैलेंज है हमारे लिए। उसके अलावा जो फाइनेंशियल है, अभी सारे हमारे यहाँ पे अहमदाबाद में 7,500 से ज़्यादा लोग ART लेते हैं। सारे लोगों की रीज़न अलग अलग होती है, किसी को 1 टाइम डोज लेना है, किसी को डे या नाइट में लेना है, तो हर किसी की इम्यूनिटी की तरह उसकी दवाई वो हो रही है। और बहुत से लोग ऐसे भी है कि जो प्राइवेट में लेना पसंद कर रहे हैं, जिनको गवर्नमेंट में आके हाई लेवल के है स्टेटस ओपन नहीं करना है, तो वैसे लोग अभी प्राइवेट में भी दवाई ले रहे हैं। तो ये भी एक चीज़ है, प्राइवेट में जो रीज़न मिलता है ART का, मैंने अभी तक सुना है कि ART जो प्राइवेट में मिलती है उसका जो दवाई है बहुत ही अच्छा क्वालिटी का आता है और वो हमें साइड इफ़ेक्ट भी नहीं करता है। जैसे गवर्नमेंट में अभी जो दवाई मिलती है, तो मेरी जो दवाई अभी चल रही है गवर्नमेंट की, उसमें बहुत सारी साइड इफ़ेक्ट होती है। मुझे भी जब स्टार्ट की, मेरी जब सेकंड लाइन डोज चालू हुआ AKT के साथ में, तो 10 दिन तक मैं कहीं पे ट्रैवल नहीं कर सकती थी, क्योंकि उससे मुझे एकदम BP लो हो जाता था, चक्कर इतना आता था, तो मैं खुद भी कहीं जाना पसंद नहीं करती थी। तो ये जो छोटी छोटी चीज़ें हैं वो कहीं ना कहीं हमारे पेशेंट के लिए बहुत असर करती है और उसकी वजह से आज बहुत सारे लोग दवाई छोड़ रहे हैं। बच्चों में भी जो दवाई अभी मिलती है ज़्यादा करके गोली के रूप में मिलती है, सिरप बहुत कम मिल रही है, कभी कभी सिरप में भी शॉर्टेज आ जाती है। तो ये सारी चीज़ें हैं जो हमारे HIV के ट्रीटमेंट के लिए असर करती है। डॉट्स एक ऐसी चीज़ है कि जो HIV पॉजिटिव जो भी पर्सन है उसे लाइफ में एक बार तो TB इन्फेक्शन होता ही है, वो चाहे कितना भी केयर कर ले, और अगर वो हो जाता है तो उसके साथ उसे फिर से बाहर आना और TB को कवर करके वापस HIV में आके जीना बहुत चैलेंजेस होता है। और वो जो दवाई आज हमें अगर इस तरह से मिले एक साथ इतने सारे हैवी डोज, तो बहुत कम लोग हैं कि जो HIV में से और TB में से बाहर आके दोबारा अच्छे होके जी रहे हैं, क्योंकि सारे लोगों के पास जो है उतना न्यूट्रिशन नहीं होता है जो दवाई के साथ साथ उसे मिलना चाहिए। आज गवर्नमेंट बहुत सारी स्कीम दे रही है, पॉजिटिव लोगों को हो या जनरल पब्लिक को हो, पर वो पूरी तरह से लोगों तक नहीं पहुंचती है। TB में भी हम देखते हैं कि TB के लिए भी 500 रुपया सरकार देती है, पर उसका जो प्रोसीजर है डॉट प्रोवाइडर से लिखवाना, डॉक्टर से लिखवाना और फिर जिला पंचायत तालुका पंचायत में जाके सही करवाना, किसे पसंद है? मैं खुद मेरे एरिया में जाकर नहीं बोलूँगी कि मुझे TB हुआ है, मुझे HIV है, मुझे वो पेंशन लेनी है। इसकी वजह से जो स्कीम भी है वो आज पूरी तरह से लोग नहीं ले पा रहे हैं। दूसरा है कि पेशेंट के तरीके से अगर मैं प्राइवेट में भी ट्रीटमेंट ले रही हूँ, मुझे अच्छे से अच्छा ट्रीटमेंट मिल रहा है, तो मुझे वहाँ पे जाके मेरा स्टेटस ओपन करना पड़ता है, जो मुझे पसंद नहीं है। मैं क्यों मेरा स्टेटस ओपन करूँ? ये भी एक चैलेंज है हमारे लिए। किसी भी डॉक्टर के पास जाती हूँ तो मुझे बोलना पड़ेगा कि मुझे HIV है। अगर नॉर्मल भी मुझे कुछ प्रॉब्लम हो रही है, मेरे आजू बाजू में कहीं पे डॉक्टर के पास ट्रीटमेंट ले रही हूँ, कहीं मुझे ज़रूर है इंजेक्शन लेने की, तो मुझे बताना पड़ेगा कि मुझे HIV है। तो हर कोई पर्सन ऐसा नहीं है कि वो उसकी HIV की अवस्था को एक्सेप्ट करेगा और बताएगा। बहुत लोग हमारे फील्ड में हमें ऐसा मिलते हैं कि मैं क्यों मैडम किसी को बताऊँ, मैं दवाई ले रहा हूँ, मैं अच्छी तरह से जी रहा हूँ, क्या ज़रूरत है मुझे किसी को बताने की। तो ये भी एक चैलेंज है समाज में कि आज खुद का स्टेटस कोई किसी दूसरे के साथ शेयर नहीं करना चाहता है। इसके अलावा डॉक्टर्स की अगर बात करते हैं तो बहुत सी जगह पे बहुत पॉजिटिव डॉक्टर होते हैं कि HIV सुनने के बाद भी अच्छी तरह से ट्रीटमेंट करते हैं। और कई कई हमने ये भी देखा है, अभी मैं काम करती हूँ PPTC प्रोजेक्ट पे, जो ANC होती है, पॉजिटिव होती है और वो प्राइवेट में ट्रीटमेंट ले रही है, प्राइवेट में डिलीवरी करवाना चाहती है। मैंने अभी तक 120 से ज़्यादा हॉस्पिटल कवर की है, खेड़ा, गांधीनगर और अरवली में। वहाँ पे आज तक मुझे एक हॉस्पिटल ऐसा नहीं मिला है कि कोई पॉजिटिव ANC की डिलीवरी कर रहा हो। अगर मैं प्रेग्नेंट हूँ, मुझे लेबर पेन हो रहा है, इमरजेंसी में ऐसा है कि डिलीवरी होने वाली है, तो कोई जगह नहीं है कि मुझे तात्कालिक वहाँ पे, मतलब लंबे समय से उस हॉस्पिटल में मेरा ट्रीटमेंट चल रहा है पर वहाँ पे मेरी डिलीवरी हो। हम इसलिए काम कर रहे हैं कि आप डिलीवरी करवाते हो तो गवर्नमेंट आपको सपोर्ट कर रही है किट के लिए और फीमेल को जो दवाई देनी चाहिए उसके लिए, पर एक भी डॉक्टर एग्री नहीं होता है। और बहुत से हॉस्पिटल में तो हमें ऐसे भी लोग मिले हैं कि ANC पॉजिटिव आ जाने के बाद एक बार लिख दिया कि नियर बाय गवर्नमेंट हॉस्पिटल रेफरल, पर वो सही में वहाँ पे पहुँची है कि नहीं, वहाँ से उसने ट्रीटमेंट शुरू करवाई कि नहीं, ये किसी को नहीं पड़ा है। तो हम वही ANC को लेके हमारा काम आगे होता है कि जो हॉस्पिटल में जो ANC पॉजिटिव आई है उसका पूरा डेटा लेते हैं, उसको गवर्नमेंट हॉस्पिटल में उसका डिलीवरी करवाते हैं और उसका बच्चा जो आता है उसे नेवरापिन दिलवा के उसका बच्चा पॉजिटिव ना आए उसके लिए हम काम करते हैं। तो अभी इस तरह का काम हमारे यहाँ पे हो रहा है। पॉजिटिव लोगों के लिए बहुत सी सुविधाएं हैं पर पूरी नहीं है, जो आधी अधूरी सेवाएं है उसे हमें पूरा करना है। इसके अलावा आपका कोई क्वेश्चन हो तो पूछ सकते हो।
Any one or two questions we can take before we start the next panelist. Any questions?
ANC પોઝિટિવ ડિલિવરીની વાત તમે કરી, ઇટ્સ ઓકે. 120 હોસ્પિટલ્સ તમે કવર કર્યા છે, તમે મને થોડુંક વધારે એલાબરેટ કરશો એના વિશે?
120 હોસ્પિટલ એટલે અમે દરેક જિલ્લામાં કેટલી ગાયનેક હોસ્પિટલ છે એનો એક પૂરી ડિટેલ લઈએ છીએ જિલ્લા પંચાયતમાંથી। हिंदी हाँ, हम पूरी डिटेल लेते हैं डिस्ट्रिक्ट का जो ऑफिस है वहाँ से कि पूरे मतलब पूरे डिस्ट्रिक्ट में कितना गायनेक हॉस्पिटल है और कितने डॉक्टर यहाँ पे गायनेक प्रैक्टिस कर रहे हैं। 1 to 1 हम खुद जाके उनको मिलते हैं, हमारा एक फॉर्म होता है, उनके ऑफिस मतलब हॉस्पिटल में क्या क्या फैसिलिटी है, कितने बेड है, कितने लैब टेक्नीशियन है, पूरा डिटेल ले गए। उसके बाद में हम पूछते हैं जनरल डिलीवरी आप कितना करवाते हो। अगर उस हॉस्पिटल में 20 से 25 जनरल डिलीवरी हो रहा है और उसमें से सारी ANC का HIV टेस्टिंग होता है, अगर हो रहा है तो कोई पॉजिटिव आती है, उसके लिए वो हॉस्पिटल क्या सुविधा दे रहा है। क्योंकि हम हर जगह पे देखते हैं, हर जगह पे डॉक्टर एसोसिएशन है, हर मंथ मीटिंग हो रहा है, पर क्या वो डॉक्टर एसोसिएशन में और वो मीटिंगों में ये चीज़ों की चर्चा होती है। हेपेटाइटिस बी है, VDRL है, HIV है, उसके लिए कोई सोच रहा है, पर किसी को टाइम नहीं है। हमारे यहाँ पे ANC आ रही है, कितने की डिलीवरी हो रही है और कितनी हमारी हॉस्पिटल में होगी वही डिस्कस होता है। ये सारी चीज़ें डॉक्टर एसोसिएशन की मीटिंग में डिस्कस होनी चाहिए, तभी हम कुछ बदलाव ला सकते हैं। VDRL हमारे लिए बहुत बड़ा इश्यू है, हेपेटाइटिस बी, थैलेसीमिया, इन सारी चीज़ों के लिए सोचना चाहिए।
Any last question?
मैं बोलना चाहूँगी कि आप बहुत ही अच्छा काम कर रही हैं, और मैं एक सवाल पूछना चाहती हूँ। जैसे आपने बोला कि दवाई के मामले में प्राइवेट और पब्लिक में आपको बहुत अंतर लगा, तो क्या आपको लगता है कि जैसे आप डिलीवरी के लिए प्राइवेट में अप्रोच भी करते हैं बट वो मना कर देते हैं, तो आप पब्लिक में ही लेके जाते हैं, तो आपको लगता है कि पब्लिक और प्राइवेट के जो डिलीवरी का तरीका है, या माँ उसके बाद प्राइवेट में बेटर फील करती है या पब्लिक में, इसमें आपको कुछ डिफरेंस लगता है?
हाँ, प्राइवेट में क्या होता है कि वो लोग क्लियरली ना बोलते, क्योंकि मेरा प्राइवेट हॉस्पिटल है, प्राइवेट प्रॉफिट के लिए है, मैंने खुद बनाया है, तो मैं चाहूँ तो किसे ट्रीटमेंट दूँ, नहीं चाहूँ तो नहीं दे सकती हूँ। गवर्नमेंट में उसे देना ही है, क्योंकि ऑर्डर पास किया है, एएनसी की डिलीवरी होनी चाहिए। मैंने लास्ट मंथ अरवल्ली की एक एएनसी की डिलीवरी करवाई यहाँ पे। रात को 10:30 बजे वहाँ से पेशेंट यहाँ आया। मोड़ासा हॉस्पिटल में प्राइवेट गवर्नमेंट में डिलीवरी नहीं होती पॉजिटिव एएनसी के, तो अहमदाबाद में आया। मैं लोकल बेस अहमदाबाद में रहती हूँ, तो मेरे पे फ़ोन आया कि इस तरह से एएनसी आई है और वो फीमेल की मानसिक कंडीशन थोड़ी प्रॉब्लमेटिक थी। तो वो डॉक्टर को अभी मुझे ये नहीं क्लियर पता कि वो मतलब है ना डॉक्टर को हाथ ही नहीं लगाने दे रही थी, पता नहीं उसके साथ कुछ ख़राब एक्सपीरियंस हुआ था या क्या हुआ था। तो जो डिलीवरी के टाइम पे जो उसे पेन हो रहा था और जो अंदर से उसकी तपास करनी थी, उसके लिए वो किसी भी तरह से एग्री ही नहीं थी। फीमेल डॉक्टर बुलाई फिर भी वो ना ही बोल रही थी। फिर क्या हुआ, डॉक्टर इतना सारा चिल्लाने लगी ना, क्योंकि कहीं कहीं गलती हमारी भी होती है। अगर मैं HIV पॉजिटिव हूँ और मैं अगर कोई ट्रीटमेंट लेने जा रही हूँ तो मुझे भी थोड़ा सा सपोर्ट डॉक्टर को करना चाहिए, क्योंकि उसके भी सेफ्टी ज़रूरी है। तो वो फीमेल ने 2 बार तो डॉक्टर को लात मार दिया, तो उसके बाद डॉक्टर ने क्लियर ना बोल दिया कि अब मैं डिलीवरी नहीं करूँगी एएनसी की, इसमें मुझे भी रिस्क है। उसके बाद हमने बहुत रिक्वेस्ट किया और मेरा 2 टीम मेंबर और मैं, हम 3 घंटे तक हम फीमेल को पकड़ के खड़े रहे। उसका जब पेन चालू हुआ तब से लेके उसका बच्चा हुआ तब तक, और उसके बाद डॉक्टर ने डिलीवरी करवाई। ना बोल रहे थे पर हमने बार बार बोला कि हम इस तरह से एनजीओ में से अगर नहीं करवाते तो हम मीडिया बुलाएंगे, हम आगे की प्रोसेस करेंगे। और फिर उसके बाद जाके वो बच्चा आया, स्टील बर्थ हुआ, पर डिलीवरी हुई। पर उसके लिए हमें है ना थोड़ा डॉक्टर को भी धमकाना पड़ा, और जो फीमेल थी उसके भी थोड़ी साइड रॉन्ग थी तो उसे भी हमें बोलना पड़ा। मतलब प्राइवेट में डिलीवरी हो जाती है, पर जो रिस्पॉन्स है वो थोड़ा बहुत ख़राब तो होता ही है, क्योंकि डॉक्टर की मेंटालिटी ऐसा है कि HIV पॉजिटिव अगर वुमन है तो उसे बच्चा नहीं रखना चाहिए। पर आज ऐसा नहीं है, अभी दवाई है कि जो बच्चे को नेगेटिव ला सकती है। 100 में से एक आधा ही बच्चा ऐसा होता है कि जो केयर नहीं लेने की वजह से पॉजिटिव आता है, बाकी तो अभी नॉर्मल बच्चे आ रहे हैं।
एक सवाल और पूछना चाहती हूँ। आपने बोला कि दवाई का आपका अपना एक्सपीरियंस है कि प्राइवेट में जब आपने लिया इलाज तो उससे अच्छा असर हुआ आपकी बॉडी पे, लेकिन पब्लिक में जो दवाई मिलती है, तो क्या आपको लगता है कि आपके बाकी लोग जो कम्युनिटी में हैं या और किसी से आपकी बात हुई है, उनका भी ऐसा ही है कि गवर्नमेंट की जो दवाइयाँ हैं वो असर नहीं करती हैं?
मेरे बाद मेरे दूसरे 5 लोगों ने प्राइवेट में ट्रीटमेंट स्टार्ट किया है। बी कॉम्प्लेक्स और फॉलिक एसिड, इतनी सारी अगर हम साथ में भी लेके आते हैं ना पर्स में, तो कोई हमारे बाजू में बैठना पसंद नहीं करेगा। और वही दवाई का कम्युनिकेशन आज हमें अभी भी मेरे बैग में है, अभी भी है, मतलब तो वो कम्युनिकेशन ऐसा है कि वो एक गोली में दोपहर में मुझे लेनी है तो कहीं पे भी ले सकती हूँ, और वो 3-3 गोली मुझे एक तो साथ में रखनी पड़ती है, और उसमें भी इतना सारा उसमें मतलब गंदा बास आता है को मुझे लेने से ही वॉमिट होता है। तो डिफरेंट तो है दवाई में बहुत।
ओके, सो बाकी क्वेश्चंस हम बाद में लेंगे सेमिनार खत्म होने के बाद, बट व्हाट ज्योति हाईलाइटेड वाज वेरी इंपॉर्टेंट एस्पेक्ट्स ऑफ government versus private, and I think more than the quality of medications, the internal content remain the same in both the cases. It is the lack of flexibility and the process adherence which is important in government. एक बार आपको folic acid चाहिए वो L1 ही आनी चाहिए, so then वो आएगी, वो फिर sugar coated और coated नहीं होगी तो उसका smell तो आएगा. So all of these things I think जो crux है, जो problem है, that is not the quality of medications, but I think lack of flexibility and procedure which needs to be followed, and lack of flexibility is related to the lack of sensitivity which creeps in. For example, if availability of syrups not being there, it's not the doctor does not want to give that syrup, but it's because it is not available. The procedures are lengthy. She also talked about the lack of support mechanisms, which especially in the government hospitals. But interestingly, the sensitivity issues which she talked about were also discussed, and we will look into the other panelists and how they view the sensitivity of doctor-patient communication, the sensitivity aspects, as the seminar progresses. Okay.
Good morning. So thank you for inviting me here. So what I will try to cover a few aspects of we will look at the patient, but from the perspective of what the patient might want vis-a-vis various differentials between the doctor and the patient. Okay. So I think that will be the perspective that I will kind of try to push. And if we are to start, and from the summary it was very clear that what was being talked about is what we might term as dehumanization in a way, right? So if dehumanization is happening, there is a serious lack of empathy, right? So if there is a serious lack of empathy, at one level, let us get into the empirical biology of it, right? So there have been studies, particularly by Jean Dessetti's group at the University of Chicago, where nothing as grave as HIV, but something very commonplace like a pinprick. Okay, a scene of pinprick was shown to a group of doctors and to a control group, and functional MRI, which is a sort of measurement of active areas of the brain. It's a proxy measurement of brain activity measured through how much blood is flowing to a certain part of your brain, etc. So that was measured. So what we saw, the results showed that physicians actually showed a significantly less activation of empathy related areas of the brain when challenged with this scene. Okay. So now that raised two questions, right? Why is this happening like this? So whenever we have empathy, you have a emotional sharing of pain from a source, right? And then you have to cognitively appraise that pain inside you. That's more about you. One is a signal and one is a kind of a processing, if you will. So what is, I wouldn't use the word wrong, but what is different here? Let's say in the case of the physicians we were talking about. In the same lab, in Jean Dessetti's lab, what they did was they did a ERP, what we call the event-related potential, right? So the technique is not so important. What is important is what the findings were in this case. There was no early empathy response. So it's actually suppressed at the very level of getting it. Forget appraisal. Now this raises a very interesting question. So we often say, even being a doctor, even after being an educated person, I mean, we have certain kind of ways of speech which start in spite of being a doctor, in spite of being an educated person, etc., right? The fact that these statements are so commonplace should by now tell us that the other kind of expectancy from which these kind of sentences come, that being a doctor or being an educated person, this and these things are inferential, is probably a wrong kind of positing in the first place, right? So there is no in spite question here. Here we are basically tagging things which are probably unrelated. I am a physician, for example. I don't claim to be a physician anymore. You have to practice medicine to be a physician. I am a medical degree holder. But I was not, I gave a medical entrance exam, and it was not based on any empathy testing or care about others. I mean, what I would actually briefly say, it probably has a bias towards not having empathy in a way, right? Because you are in a certain kind of a, you have to nudge somebody away and then get ahead, etc. So it kind of streamlines to that. There's the added aspect of that, you know, I became a physician and not an engineer, not so much because of any love of biology, but because of how the mathematics versus biology paper numbers turned out, right? That's largely the case. And that lack of choice actually brings down the common denominator, money, right? So there is more money in it, so I am there for sure short situations of money. The reason why I'm saying all of this is we have to understand how doctors are produced. Who is the doctor? Who is this person? Where does he or she come from? What is he looking at when he's looking at someone, right? You cannot expect somebody from Mars with a very different set of value systems and priorities coming in. Neither is there training as such. Okay. So training sounds nice, okay, but there are certain structural issues which I would like to kind of now flag off in doctor-patient relationship and communication, and more so from the perspective of the doctor, given that the patient is often dehumanized, okay. Now dehumanization may not appear to us as such, but let us use the harsh term, okay. So let us remember that the physician's job is not all empathy, okay. I mean, God-men are there for that, but then they only have a very limited kind of role in that, right? So it's not all empathy. But the fact that there is a God-man market for even diseases, I think tells you something, right? But at the same time, it cannot be all empathy, it is also problem solving. So we can actually look at the role of the physician to be part empathy and part problem solving, right? Both of them together. So let us first look at what are some of the problems per se, and maybe actually in the statement of the problem or the way I posit the problem, the possible solutions are kind of embedded in, right? First of all, when you de-individuate a person, kind of, you know, in that setting, number, barcode, etc., third bed, you know. So when you de-individuate a person, right, we may think that when you go to the bedside, I'm talking about a hospital scenario here, right? When you go to a bedside, you have the file and then everything comes back. But when you do this to a person who is a physician, day after day, year after year, year after year, then what you are looking at is really a 5-minute hold of information of parameters. There's no person involved so much, right? It's a structural issue. It's a hard structural issue. It is not as if the doctor has to be a particularly monstrous person for this to happen. We must understand this, right? So de-individuating practices are something flagged off, and in what I'm stating, it's partly empirics of other people, and particularly I would kind of tell all of you to go look at the work of Umar Sultan Haq, quite a trailblazer in this sort of work. Okay. Then there is the whole issue of impaired patient agency. Okay. And this is a very tricky problem because a patient is there because there is some impaired agency in the first place typically. Either you are ill or either you are not in the best of your kind of prowess in whatever of speaking up, you know. You are in any case in a somewhat compromised scenario. That's the whole point of you are in a patient's role. But given that, given if a healthcare system, including the doctor, knows that, what can, in a complementary way, boost up that lack, given that we know that a patient is coming with that lack? Again, structurally, you cannot attribute to the patient. Why didn't the patient speak up, you know? Because the patient is a patient, you know. He's there or she's there because that there are certain problems and that agency of that you, even if you feel tired, you do not have full agency. We are talking about patients here, okay, with a real problem. Now I would like to come to something which is pretty important. And there have been multiple empirical studies which show this, that dissimilarity between the patient and the doctor there's a huge role of dehumanization. So I think there is something in I think Old Testament or something which says, you know, do unto others what you want. Old Testament, right? Huh? Old Testament, one of the Christian books. So do unto others. Now there's a very interesting question, others, right? Now it is harder to do unto others, to do what you would do to yourself, if the other is different from you in more parameters than less, right? And there have been huge number of empirical studies about this. So let us flag off certain things at first, you know. What kind of stares at your face is class. Rich doctor, poor patient. Okay. Male doctor, female patient. Upper caste doctor, lower caste patient. Okay. Bengali doctor, Gujarati patient. These are all parametrics which make a person different, a doctor different from a patient, right? All are impairments of communication. See, in a doctor-patient scenario, people are not communicating for, you know, entertainment's sake. It is very crucial to patient outcome, right? So we must understand it is part of patient right and good medical and clinical practice to ensure good outcomes, right? We are talking in that setting. Now I would like to say, so we flagged class, gender, language, caste, and you can go on and on and on about this, right? Now let me tell you that something recently has happened which has compounded this problem in India at least. Okay. See, the solution to this, first of all, there are two kinds of solution to this, what I first said, and then I will come to why there's a huge problem of this kind in India now, especially for the last 2-3 years. You will see the problem getting very grave in about 5-10 years' time. See, the one is that you cannot, in let's say metropolitan areas, you cannot predict who your patient is. So your best bet is diversity of the doctor population, because you cannot predict who your patient is. Okay. In the same time, where populations are way more homogeneous, the way to do it is actually actively promoting homogeneity. A different strategy, right? Makes sense, because you know, again, if the patient group is predictable. Same reason, right? In short, more migrants versus less migrants. Two scenarios. your doctor population has to be metered or titrated differently. Now let me tell you what is the big problem that has come in. It's called NEET, N-E-E-T. So now you have a NEET exam, it's an all India exam. Earlier every state used to have its own state medical entrance exam. Okay? State medical entrance exams were based on state board syllabi. In any given state, okay, a CBSE person or ICSE, a Delhi headquartered board person essentially, and the state board person typically would be different in multiple axes. Class would be a very important one. Okay? Very often caste, very often rooted urban versus rural, this difference would be there. Okay? And urban versus rural directly translates into rootedness and connection with the people, etc. So in a way, NEET, given that it promotes urbanity, richer people, okay, less rooted people, in a sense all factors that would make doctors who are structurally alienated from most of the patients. Okay, it's a huge problem. You are only getting the first crop of NEET doctors being produced right now. The effects of it you will see in 5-10 years. It's going to be disastrous. Okay? In fact, there should be a study of healthcare outcomes, okay, of keeping all parameters same, NEET versus non-NEET doctors in a certain era. You know, what changed, what shifted, including patient scenarios, right? See, for example, there's a very basic idea here. In a Delhi board school, it is not compulsory to learn, in most cases, the language of the state. Often not even available. In a state board, that's unthinkable, right? That you're not learning, so Gujarati, in a Gujarat state board school, it's a ridiculous idea, you know. Now, if the doctors in Gujarat are being produced from Gujarat state board or CBSE board, it matters to the Gujarati patient. You know, it's a huge, it hugely matters. So, I would finally go on, there's also issues of mechanization. Nobody is being a Luddite here, okay? That, you know, machines are bad. But when the machines do not have an intervening human interface, that you are left in a machine, or you only have the machine, it adds to that dehumanization, adds to the lack of patient agency. And this leads to empathy reduction from the doctor's side because they are also not seeing. There's moral disengagement if you have these differences, right? For many of us in this room, let me do a small thought experiment. You don't have to give me the answer, okay? If a beggar on the street suddenly begs to you in English, you will probably take more notice. Right? Similarity. It is evoking, you can call it empathy, you can call it surprise, whatever it is. You are probably far more likely to actually put in 5 takas. You know? So this is just a small example. I can speak about me. That defines me. I cannot predict about you people. But try to think what you would do in such a situation. Again, as I said, in the way I stated it, the solutions are probably embedded. Individuation. Doctor-patient profiles has to, the direction has to match more and more. There has to be district quotas in medical colleges, for example. Class quotas, okay. Caste quotas which are representative of caste population percentages. Okay. Any form of percentage based discrimination, you can, these things you can do structurally. The other part, you know, changing the doctor, well, that's a very tall order. Okay, thank you.
One question we can take before we proceed.
I think you made many wonderful points. I must say it's quite a learning exposition. So I come from analytics, and we are seeing massive uptake of healthcare analytics right now. So do you think that maybe some of these are actually accelerating that? Because if the system becomes mechanized, machines can take over. So do you think as we push this kind of a mechanization, to put it in the broad term, the various problems that you are saying, would machines be a preferred way of getting at least some of this information before the person proceeds to a quote-unquote a specialist who is possibly now acquainted with at least the basic information that
The profile of the patient, let's say.
profile of the patient, questions that you would have possibly not even asked because of the kind of barriers that you mentioned, would at least be captured by the machine?
See, it doesn't so much matter whether a machine does it or whether a nurse does a prehistory. Okay. What matters is what is structurally different between this end processor called the doctor and the patient. The detail of information will not change these differences. What you are betting on is intrinsic empathy. What I am trying to say is, let's not bet on individual empathy. Let us bet on large factors which empirically show lead to better outcomes. In a sense, let's not wait for a benevolent dictator. Let's have democracy, you know, that's all.
I think analytics will dehumanize doctors also. Okay, so patient को तो dehumanize कर दिया, doctor को भी dehumanize कर दिया.
So I'm taking a negative of the negative.
Yeah.
No, see, they are not exactly dehumanized. So if I am a upper caste, personally, I am a upper middle class, upper caste Hindu Bengali, Brahman. Okay. You match this patient profile, I am full of humanity. See, it's not as if one is dehumanized per se. So let us not let's not fall into the trap of this person is bad, doctor or patient, whatever. If we know that empirically there are ways in which the whole gamut of this scenario can be shifted for the better, let's try those.
So I think Dr. Chatterjee talked about the structural issues which can lead to empathy or lack of it, the humanization, dehumanization, individualization, de-individualization, and I think very valid points being discussed. But let us, but for all practical purposes, doctors get trained in their course of treatment. That means offering treatment for 10 years or so. They see different patients, and they will have diverse patients coming to them. I think Dr. Balaji will throw light upon how some of the aspects of dehumanization, practically speaking, how do they take care of transparency while communication, so that, and he deals with the chronic patients, so adherence is one of the very important aspects of treating diabetic patients, and without empathy and without individual attention, it's very difficult to have. As such, in chronic diseases, the adherence rate is as low as 55% across the world. So let us hear from Dr. Balaji how he takes care of these issues.
Thank you. So first of all, I want to thank Dr. Rajesh and the entire CMHS team for inviting me here to give this talk. So it was very interesting from the, the other panel members, the kind of discussion that we had. I do agree a lot with what Ms. Jyoti has mentioned. I was trying to listen to her very carefully about the kind of treatment that we get in a private setup vis-a-vis what you get in a government setup. There are several factors. I'll try to probably come to that in my presentation. And also what Dr. Chatterjee mentioned, about this dehumanization, because that connect is very, very important. Unless you connect with the patient, you will not be able to provide the desired outcomes. And especially in a kind of condition that I treat, chronic disease management. Diseases like diabetes, other metabolic diseases like hypertension, dyslipidemia, heart disease. So I'm more into sort of preventive care. And it is very important to establish an emotional connect with the patient. Because these are not patients that you're going to see them one time. It's not like an acute illness that you're treating. Let's say if the patient has malaria, dengue, he'll come to you for one time, you treat him, and you might not even see that patient after that. But here, you know that this person is going to come back to you. He might be your patient for life. So it's very, very important to have that connect. Other thing is to motivate the patient. That's very, very important. Until and unless you motivate the patient, he or she will never be able to understand what are they dealing with. So motivating, educating them, and sort of self-management. So teamwork you get into with your team, as well as the patient is one of the team members in that. And then you keep acknowledging them at different stages. So what you have done for the patient, what outcomes have happened. So on that note, I'll go to my presentation. So doctor-patient relationship requires a lot of teamwork, especially in chronic disease management. Now I'm actually a consultant physician and diabetologist. I work in a place called Padmanabh Nagar. It's a suburb in Bangalore. I also go to other clinics, other hospitals within south part of Bangalore. So I've always been passionate about chronic diseases, especially diabetes. And I've been treating it for the last 8 to 9 years. And I have learnt a lot within my experience, because like Dr. Chatterjee said, what we learn theoretically in medical schools might be very different what you want to learn. And one word, if I may say, is passion. If you have passion, you can have innovative ways of treating patients. So I'll try to cover that in my presentation. So these are some of the aspects that are very important in doctor-patient relationship. Pardon me if there are a lot of theoretical medical things. I'll try to simplify them. So first of all, we need to value the patient. Every patient is different kinds of personalities. You have people, who would look on to Google, other information, come to you already well informed. You have people who come from villages, rural areas, who have absolutely no information. Let's say, for example, in my practice, diabetic patient coming with a foot infection. So they don't even know that they have diabetic neuropathy, which can lead to this foot infection. Or you have other patients, from higher socioeconomic status, let's say a politician or a person from an IT background. So all kinds of personalities we get to see in metropolitan cities. So we have to respect the patient, first of all. Utmost respect and listening to the patient. So we need to value them. Secondly, the physician characteristics. So every treating physician should first of all have sound knowledge about the condition that they're treating. And it is very important to listen to the patient. Listen to the emotions, empathize. Many a times in chronic disease management, it's like a story. They've undergone a lot of things, right from infections to maybe complications in the eye, heart. So you need to carefully listen, at least the first time, the first visit that the patient comes to you. And you can then be able to apply this knowledge. Then balance of power. So once you've heard out the patient, you have discussed with the patient what is his or her condition, the current presentation, and what would be the course of action. What are we expecting in the next few months or years down the line? So we need to come to a consensus that is based on the presentation, the diagnostic investigations, and how we examine the patient. Then we can come to a consensus. So within this 3 space itself, you can try to emotionally connect with the patient. And then finally, commitment. This is very important for a chronic care model. So you have to be committed to the patient long term. Even sometimes, patients, I have patients coming from all over the country, even from other parts of the world. So they don't have access to you all the time. So can you give them some advice on WhatsApp? Are you accessible through the phone? So these are small things that establishes a connect with the patient. Yeah, so these are all some of the issues that we face. So there's a lot of mistrust. So now there's so much of information available. Patients are giving feedbacks online. So there's a lot of confusion among patients. Like you even heard from Ms. Jyoti. She's telling, I don't know whether to believe this doctor, not to believe. Every person is having a perspective. So there's a lot of noise going around here. Poor adhere. So if you do not trust your treating physician, definitely you will not adhere or comply to the treatment that he or she has given you. And suboptimal, all this eventually will lead to suboptimal outcomes. Now she did mention about cerebral tuberculosis, what she developed. So probably better awareness, education, spending time would probably make the patient realize what can happen to the patient if they do not adhere to a proper plan. So discussion and being open with the patient is very important. And then the last one is violence. So that is one of the reasons when you have not established a connect, patients' questions are unanswered. And this is actually more common in an acute setting where a patient otherwise is normal, what the attenders feel, and they feel that there is a sudden deterioration that has happened. So they're not able to accept it. The first thing is like a human response is denial. And then there is an emotional outbreak. That can happen in chronic care as well. So I'll come to a few cases in that. I'll try to show you my best practices because currently if I have to talk about diabetes management, so HbA1c is one of the markers for blood sugar control. So if you see currently around the world, it is only around 40 to 50% of patients around the world who are able to achieve this control. Fortunately in my clinic, with Dr. Rajesh, we've done a research. At least initial interim analysis has shown that almost 85 to 90% of patients are having good control. So I feel there are several factors attributed to that. So I'll try to cover a few of them here. Now this is something that I have developed. What I feel is that there are two aspects here. One is from the team's perspective. So you have diabetes educators, you have diabetic nurses, you have the other staff, dietitians. So I feel that all of them should have good knowledge, first of all, about the condition that they're dealing with. And I myself should empower them so that they can further educate patients and they establish a connect. So that connect, dehumanization, what you mentioned. First connect should happen at that level. So for example, if my staff, they're taking the history for the patient, at that point itself, the way they communicate and ask questions, the patient should feel confident, okay, this person has got a lot of sound knowledge, the paramedical staff itself. So knowledge and empowerment of staff. Secondly, difference and access. So from my perspective, what difference I can bring about on the table vis-a-vis what is currently happening in practice, which is not happening in other clinics or hospitals. It can be several things. For example, I can use a particular application for monitoring of blood sugars, treating them. I can have a certain style of educating patients on insulin, how to take it. Or it can be several other things. Some difference which they have not seen somewhere. So then it will strike them, oh, this doctor is doing something which I have not seen before. And then access again. So this access is very important for chronic care. So you have patients, let's say like HIV, or you have patients like diabetes. It's a lifelong disease. They have to deal with it. So at any point of time, they can develop a complication where they want to approach you. So can you give them that access? It can be either through phone call, or they want to come and see you in person. But you're not charging them for that consultation. That itself establishes an emotional connect. Normally what happens, every time you want to meet the doctor, he'll say, you pay my consultation charge. Or it can even be through WhatsApp or Skype or whatever, so these kind of things. So these two elements are very important. So from a staff perspective, from a doctor's perspective, and this I feel would definitely lead to a certain emotional connect. Once that connect is established, then that patient has a lot of confidence in you. He has a lot of confidence in your staff. He or she will listen to you, want to listen to you. I have patients where they say, I love coming to your place. You're so friendly, you keep smiling, you keep explaining everything. So that kind of a connect should be established. I love your staff, your staff nurses, he tells me every time, take care of your feet, use proper footwear to prevent an infection. Or he explains me about this HbA1c, why it is important. So that empowerment again of the staff, very important. So all this can lead to emotional connect. So if you have an emotional connect, then now you're a team. You're a team of the paramedical staff, the doctor and the patient. Then it is very easy for you to achieve the desired outcomes, what you're looking for in the long run. And you can keep monitoring and ensure that the patient is free from complications. Recently, one of our data actually, you see, this was a multicentric study. This was presented this month. in Berlin. We had an international conference for diabetes. So I was also one of the investigators, if you see here. So this was about digital diabetes management tool for monitoring and counseling patients treated at Apollo Sugar clinics across India. So basically we have this Apollo Sugar application. Through that, we also have something called the health coach. So any doubt, anything the patient have, they can even chat with us. Or sometimes when we start insulin, if we want to titrate the insulin doses, we can do that through the application. Dietitian is also accessible through that. So again, these are all factors that allow better contact, better access, improves the connect with the patients. And this we had seen had improved outcome. Now this is a multicentric study. It is done across India, north, south, east, west. Everyone had participated in that. Also doctors from Calcutta, some of the doctors from Apollo. So we had good outcomes. We presented this as a poster in Berlin recently. This is the patient care pathway I follow in my clinic. More or less it's a standard protocol in most of the Apollo Sugar clinics. So meeting and greeting. So the first contact that the patient has at the registration staff. So there itself you have to be very courteous, irrespective of the age group, the ethnicity, the caste, whoever the patient is, religion, etc. So after that, history taking. So at this level, my nurses will come into play. They take a careful history, the past history, medication, surgeries, everything. And then they take the patient to the dietitian. So the dietitian, what happens is she will explain certain tests which are important for the patient based on his profile, because every patient is different. We'll have to individualize the treatment. And then finally, once all the tests are done, they come to me for consultation. And after my consultation, then there is a nutritional consultation. So for that particular patient, tailor-made, we give them a meal plan based on what is the caloric requirement, how much of carbs, protein, everything. So that is calculated by the dietitian. And then this stage is very important because after the consultations here, then they are followed up. So we also have a call center. So they will ensure that they call them and remind them that you're scheduled for the next follow-up. And then they also ask them about how are you feeling? Do you get any hypoglycemic episodes? Are you adhering to treatment? So the connect is also established at this level. And then, so this is the call center, the patient engagement center. So they have data from backend where they can access the patient. So this is broadly, if I say, the pathway that we employ there. Now, actually, if you see, there are different methods that can be used for managing a patient. There's something called the paternalistic method. That means, so that means what happens is, me as a doctor, I feel this is the best treatment. I will not listen anything to the patient. He has to listen to me, which happens. Several doctors follow that approach. Other is informative model, where there is a lot of exchange of ideas, information. Patient will share their concerns. I will tell what is their present condition, and then we go about with it. Then interpretive. Interpretative is basically based on the results, examination findings. Then you come to a conclusion. And this deliberative model, this is the best model because both of you are working as a team. You're deliberating towards a certain clinical outcome. So this is an ideal model. What happens is we as doctors, when we finish our medical education, the first thing that we do is we take the oath of Hippocrates, that do no harm to the patient. We have to be very sincere. There's no discrimination and all. So this is a very interesting thing. I don't know, have you heard of this Procrustes? Yeah, I think this gentleman here, he's nodding his head. So very interesting. This guy, he was a thief in a small town in Greece. And what he used to do is, on a highway he had his house. He used to invite people on the context of giving them good food, serving them well. And then he used to then tie them up in a table and either chop off their legs to ensure that they fit within that bed, or if they are people who are a little shorter, he used to extend their body so that they'll fit in that particular space. So it was a very sadistic way that he was doing. So why I'm trying to show you this slide is that basically it's just an analogy where I'm trying to draw that you should not cut short too much information that you're trying to give the patient, because then what happens, they don't understand their condition, they don't connect with you. Neither you should give too much of information and you set expectations which are beyond what they think. Then you do not deliver at that, then the patient will never come back to you. So it is very, very important based on every patient to individualize, understand the case and get the expectations right. So explain the current condition, you monitor the treatment progress and you explain the outcomes. So for chronic disease management, okay, this is what I can expect in terms of your HbA1c. Let's say you've already come with some amount of kidney damage, what we call diabetic nephropathy. we can expect an improvement of nephropathy or retinopathy. So you're trying to set expectations. It can even be related to medications, what Ms. Jyoti mentioned. Now that I'll come to that in the last stage or during the discussion. Because medications, they cause a lot of side effects. What if you tell them upfront, this medication can cause some gastrointestinal side effect. This medication can cause a urinary infection. It will give you this efficacy, but some patients can get this. So be wary of that. If you do get it, you get back to us. And all this is done by a very robust data capturing. I'm very data centric. I have a lot of data in my clinic. That's why I'm able to do research. I'll come to that next slide. So all this will lead to further trust and compliance in the treatment. This is the registration form. Yeah, this is my own protocol. So every patient who comes to me first, there is a new patient case sheet protocol and follow-up patient. So these are all the bare necessities. What is the age at diagnosis? What is the duration of diabetes? Family history? Any skin markers for insulin resistance? What are the medications they're taking? Surgeries? All this has to be captured by my diabetic specialist nurses. Then they will come and give me a brief history. Then the case becomes very easy. As the patient comes, already I'm talking to them in terms, you already had a bypass surgery, you're already on this drug. So they feel very nice. I know the case already. And then review patients. At every follow-up visit, we'll have to monitor and see how they're doing well. So I'll just show you some data here. This is how I maintain. So I have hard copies and I have even we have a software. So hard copy, if you see here, this patient, he came to me somewhere in December 2017. His HbA1c was 12.9. Then within a month, we brought it down to whatever, and then it is maintained at 6.6, 6.1. So ideally, HbA1c should be less than 7. That is the goal. And all this data we capture. So what drug I'm giving, what has happened to body weight, what has happened to fasting postprandial. And this will be clearly explained to the patient at every follow-up visit. So he or she is also motivated. Other thing what I do is, people who achieve this control, I also give them a certificate of appreciation. So that makes them feel even more empowered. So some patients we have done that as well. Feedbacks, yeah, so this also is important. If they give feedbacks, other patients also online they can see. Testimonials, so these things are also important. And this is my last slide actually. So violence is an outcome when you're not able to deliver on all these aspects. When you don't have an emotional connect, at least in chronic disease, then the patient will never trust you. And suppose if a patient has a hypoglycemic episode, which can be very life-threatening as well, if you're not accessible, you don't give them that information, they can turn violent, they can come and say something to you, or even write negative reviews. So it is very, very important. These are some of the signs of a patient turning violent. So staring at you, his tone of voice might change, he becomes more aggressive, he's anxious, mumbling, pacing. So all these things are important, that if you establish a good connect, even if something goes wrong for a patient, still he will not find fault with you. He will try to find a solution from you, and he'll be a patient for you for lifetime. Thank you.
Thank you, Dr. Balaji. And Dr. Balaji rightly highlighted some of the processes followed in the clinics, in his clinic particularly, which at least give the perception of empathetic doctor, establishing patient connect, maybe through technology, for example, having an app plus a coach, or maybe through call centers. But these are some of the technologies or processes which can be included in the day-to-day practice, so that at least the connect is strengthened. And this is especially important in chronic conditions like diabetes. And now I would request Dr. Indu Arneja to
Good afternoon, all of you. Can we reduce the volume? I think it's slightly more, isn't it? Is it okay? It's okay? Great, okay. Having heard three speakers, can we switch this off? Can we switch this off? Yeah. So I think having heard three speakers from their point of view, Jyoti, you really did a good job by telling us how do the patients feel. I mean, it was really very heartwarming, and especially I thought you are from an NGO and you are working with the patients. But being a patient and then being with the patient is altogether a different journey, and she's really been able to show us what a patient goes through, and the kind of questions you are putting, the medicines they are giving, they are not good quality, and they are giving so many medicines. I mean, mostly we get to hear that in the government hospitals we are not given enough medicines. And the different aspect that you talked about, they are giving a lot of medicines and they smell so bad and they actually smell even my bag. So that shows the gap between them and the people who are providing healthcare facility. Incidentally, patient is supposed to be the most important team member for any healthcare delivery system. Unfortunately, that becomes the last priority. And we are never able to connect with the patient. Thank you so much, Dr. Rajesh, that you invited Jyoti, and I'm glad that you shared your journey and you shared your pain with us. I'm sure that will enlighten us in how to actually work on our communication. I think that's the need of hour. Very beautifully, Dr. Chatterjee talked about the functional MRI, which says that there are some structural deficiencies in us which pushes us to lack empathy. I mean, I would not venture into that because I believe the day you decide I want to work on my empathy, you will have structural changes in your body. And I've seen number of TED Talks, I'm sure even you may have seen, I don't know if you have seen or not, they talk so much about actually bringing in changes in your brain structure if you decide to achieve something. And once you plan to work on your empathy, on your attitude, or on your lifestyle, you will simultaneously have brain changes. So I think that's the relief I get after listening to Dr. Chatterjee. Don't worry, if they lack empathy, they can work on it. But I can't give this excuse that we lack empathy because I have structural problem, so you got to take it. You got to believe it. I will not take that. And also because I am a very passionate trainer, and I believe we can change people, we can transform people, we can enlighten people. So I still have that, ray of hope in my heart that I can transform people, I can change people, and I do get this feedback from people, especially with the medical professionals with whom I conduct training. When I get to hear, the feedback that we didn't know about it, we never thought about it. So I would blame it primarily to the lack of training. The syllabus that we have for the medical professionals or for the nursing professionals or even people who are working in healthcare, that they have not been trained. Somebody who becomes a pilot is not born pilot. He learns flying. So if you can learn to be a clinician, you can learn to be an empathetic clinician. You can learn to be a good clinician. So I have that ray of hope that we can bring some changes. And with that passion, I'm trying to, work with medical professionals and paramedical. I've conducted more than 1,000 programs in the last 4 or 5 years. Every day, I'm at one or the other training program. So what I understand from even Dr. Bala, you have been a wonderful speaker, especially when you talked about how do you make connection with your patient and how do you really win their heart and soul. This is what probably Jyoti is looking for. Probably you were looking for a doctor like Bala. I believe and I wish we have more doctors like Bala who actually can, understand what do my patients want. So what I understood from the three of you who talked about it in my mind, what it says, that there are primarily 4 objectives that we are looking for when we are talking about healthcare delivery. One, we want to improve healthcare outcome. That's one objective. Second is we want to reduce the number of errors in patient care. I think Dr. Bala will agree with me, and even you will agree with me, when we fail to give right delivery of treatment, when we actually make errors in patient care, when patient suffers because of our negligence, that's what we want to really, really reduce. Third most important health outcome that we want is that we want to improve the patient's safety. That has never been our objective. Believe me, I'm in healthcare for the last 30 years. We never considered the patient safety as a primary health outcome, but now we are realizing, because a report by JCI has revealed to us that medical errors are 3rd commonest cause of death among patients. This is not a report from India, this is a report of US. We haven't done any study in India, but I am sure once we will do it, we'll get to realize probably we are standing at number 1. I will not be surprised if I get to hear that. So patient safety has become another important, objective of healthcare delivery. And 4th most important, I think, which you are addressing very well, Dr. Bala, that's about patient satisfaction. And doctor-patient relationship is primarily dependent on your patient satisfaction. Patients, when they come to us, they hardly know your clinical skills. They don't even check your credentials. If your behavior is good, oh, you are a good doctor. And incidentally, Indian population is more feeler than thinker. So if they have a feeling, oh, you are a good doctor, You are a wonderful doctor, they will not check your credential. That's why quackery is still in huge practice in our country, and they are making more business than actually qualified people. So what I would like to talk about, understanding what you have talked, there are majorly two areas that we need to work on. One is patient and second is on the doctor. So first I would like to talk about what do my patients expect from me. And if I understand that, then it becomes easy for me to design my delivery to the patient. And what I heard from you, Jyoti, I understand patient wants, somebody should talk to them. Somebody should listen to them. Somebody should understand what they are going through. When a patient comes with pain, they haven't started having pain while entering the hospital. Maybe they are suffering with the pain for last night, for a day, for a week, maybe for a month if they have actually visited number of hospitals. So that means they have come with lot of suffering and pain, and what they are expecting from us is probably the proactive attention. That yes, I'm ready to help you. I want to help you. You are welcome. I shall help you. And for that, when I talk to the doctors and I ask them, you need to communicate that yes, I'm wanting to help you. They say we don't get so much of time. We can't talk to patients for so long. I always tell them, you don't require time for that. You require attitude. If I want to help you, my immediate reaction on your entering the room will be, I will make eye contact with you. I'll smile at you, I'll nod you, and I'll show you a chair. That itself is enough to build rapport with my patient and communicate that yes, I want to help you. So understanding my patient's expectation, simple things like, if I'm giving you 10 medicines, let me tell you why do you need to take all these 10 medicines. I have seen patients in my own family, patient who underwent bypass surgery. She was put on anticoagulants. Nobody told her that you don't have to stop it and it's a life-saving drug for you. She in between stopped the medicine. After 1 month or so, she went into hemiplegia. She was on bed for 3 weeks, 4 weeks, and unfortunately after that she passed away. And what was the error? We failed to communicate that these are the medicines that are mandatory. You don't have to miss this medicine. So when a patient is given medicines, we need to talk to them. And I don't give this responsibility of talking to the doctors alone. Very beautifully you said you have educated your nurses now who are diabetic nurses. So that means they exclusively specialize in diabetes. So they know if a patient has a question, they can answer, they can explain. It's only a matter of knowledge. And if we can actually have people with us who can learn how to handle these questions, most of your questions could have been handled by even a nurse if the doctor could not have given you time. But that would only happen if we are thoughtful that we should have people who know. Government setups are not deficient of resources. Government setups are not deficient of even work power, although they always claim we are short of manpower, we are short of manpower. And because I take number of sessions in government setup and I always tell them, tell me as a nurse, what all do you do in your 8 to 10 hours duty? It's just giving medicines and injection, that's all. What about health education? What about talking to the patient? What about answering their questions? So most of Jyoti's questions could have been answered even by a qualified nurse had she been trained how to do it. Like we can have diabetic nurses, we can have HIV nurses who could answer most of your questions. So that means it is not a big expectation. Patient would want, somebody should talk to them, explain them what they are going through, what is the duration, how long will it take for me to recover. For example, if a patient comes with a fracture foot, his immediate question will be, how long do I have to wear plaster? Will I be able to walk? Will I be able to pull my rickshaw in case if he's a rickshaw puller? So do we really address those questions? If we do, I think patient goes back satisfied. But most of the time we are treating the illness and not the patient. So as a result, patient is never happy, never satisfied. And most of the aggressive reaction that we are receiving from the patient and the community or the society, it's all because of communication failure. Studies have shown that in 71% of the cases where the patient had sued the hospital or the doctors for medical negligence, the problem was not medical negligence, it was communication failure. That is the importance of building communication and building rapport with the patient. But incidentally, we do not focus much attention to it. Now, talking to talking about the whole aspect from the challenges that the doctors or the healthcare professionals are facing. No doubt, in government setup, there's a lot of workload. Also, there is no clear-cut responsibility fixed with the people, that this is your role, this is your role. So there is a lot of, mixture and ambiguity in the responsibility. So it's everybody's hospital and it is nobody's hospital. That's the problem. In private setup, yes, people are communicating, people are making relationship, people are attending the patient, but again, how many of them do it willfully? How many of them are happy to do it? That's a question to be answered. Because most of the doctors who are trained in a government setup, they are so used to working mechanically that they actually forget the importance of building rapport with the patient or treating the patient with respect, with care, making them feel wanted or accepted. Am I right, Dr. Bala? Do you agree with me? If you have an experience. Whereas it's so important because that's going to actually decide the efficacy of your treatment. Like when she said the medicines are not good, it's basically the perception. I mean, even if you'll get the qualitative examination of the medicines done, most of the medicines will clear. Because I'm sure when the medicines are bought by the government sector, they're not just bought like this. They go through the proper system of making sure that the quality of the medicines are maintained. But again, so since nobody explains, nobody talks, so you have an assumption, and communication affects the perception of care. And when I talk to the nurses, I tell them, see, sometimes when you go to pediatric ward, you will hear from the child, they'll say, I will not get the injection from this sister. We have heard this? कई बारी आपके साथ भी ऐसा हुआ होगा, किसी के देख करने इनसे इंजेक्शन नहीं लगवाना. Then the child will say, इनसे लगवा लूँगा, ये ठीक है. अब इंजेक्शन तो इंजेक्शन है, कोई भी लगाए, दर्द होगा. But a nurse who is nice, well behaved, makes the patient comfortable, she seems to be a good nurse. A nurse who is rude, who is not very friendly with the patient, तो पेशेंट को लगता है बहुत एटीट्यूड है और तब उनको लगता है कि अगर इतना एटीट्यूड है तो इनका इंजेक्शन भी उतना ही पेनफुल होगा. So that is how our perception about the treatment changes. So, and most of the private practitioners who are doing a successful practice, they would have wonderful communication skills and interpersonal skills. So that's the importance of interpersonal skills that we need to understand. Of course, no doubt, there are a lot of challenges in healthcare. Patients are now more aware because they have Dr. Google at their hand. Just two days ago, I was interviewing a doctor and I said, what do you feel about Google? He said, oh, that Google really helps me. And that was probably the first time I got to hear from a doctor that Google really helps me. He said, they come so well prepared that my task becomes easy. I said, what a beautiful attitude you have. Normally we are resentful. When patients come to us with, half-baked knowledge, we feel very bad about it. But it is so easy for them. He said, they already come prepared, and when they ask me what are the risks involved or what is the possibility of complication, when I tell them, yes, there is a risk, and I'm sure you must have read, because you have already gone through Google, so you must have seen that it says that there are some risks. So that way they would feel it is not the doctor who has done something wrong, the procedure itself has some amount of risk or the possibility of complication. So that's how I think we really need to understand things are changing, especially in the last 10, 20 years, things have drastically changed. People are educated, they have access to information, they want more explanation, they want somebody to talk to them, and especially now when they come to a private setup, they are paying for the service, so they look for value for money. They want their, the time from the doctor. Now we can't say I don't have time. If they say you don't have time, I can go to another doctor. So I think doctors now need to understand this, that we need to change our style of practice. Very rightly said by you, from paternalistic style, we have to actually go to the patient-centric communication, where we have to design our communication from the patient point of view and fulfill their needs, fulfill their requirements. I think with this, I'll end my session here, because what I understand, and I'm sure we got an understanding from all three of the speakers, that this is something we really now need to focus on. We cannot deny the importance of building rapport with the patient, and doctor-patient interaction has become equally important as the clinical work that we do with the patient. Thank you so much.
Thank you, Dr. Arneja, and very well summarized. Some very important actionable points which can be incorporated in our day-to-day life, busy life of doctors also, so that the perception at least of connection and empathy can be established. Now, time for Q&A. Any questions? You can direct to the all the panel members or specific panel members. It's your choice.
I just had a question. It can also be taken by Dr. Indu, but I think we couldn't take questions after your talk, Dr. Balaji, because time thoda extend ho gaya tha. You know, in India, most of the research is not about physician-patient interaction. It just started. We just started looking at physician-patient interaction, something that's been in the US or Western world for a very long time. And I always felt that one of the reasons is because in the priority level, hamare liye, that's always been the lowest, because you have so many other issues related to health outcomes in the country. And when it comes to demonstrating patient empathy or moving from, say, paternalistic style or information dissemination to dialogue, the physician-patient ratio is quite bad, especially in government hospitals. It could also be in private hospitals, because we know that when a hospital is really good, people are ready to wait. I mean, they wait for 2 hours, 3 hours. There is a line, you know, they don't mind waiting because doctor acha hai, so I want to go to this doctor only. So the crucial aspect, like in a perfect world, we would have all the time to communicate, to have that connection, to talk to them. But when you don't have time, and if it's a repetitive thing for all doctors, or maybe some doctors, say civil hospital maybe, where they say if I start having a dialogue and talk to them in interpretive stance or dialogic stance, then I can't, I mean, then I'll not be able to see so many other patients. So first for you, have you encountered or have you had to balance? Have there been times when you see the need to communicate, but you also see that, look, I only have 5 minutes or 10 minutes or 15 minutes, maybe in this hospital or in your previous experience, and then how do you balance? Because that's the key, especially for government hospitals. I think that's the key, the balance.
Correct. I completely agree with you. So it's a very valid point. So in my practice, what I do is I have set a number that I will not be seeing more than 30 patients a day. Otherwise, I will not do justice to those patients. Might as well see less and do a good job than see more and do nothing. So I am very, very clear in that. Going forward as well, 30-35 patients I'll see. And as I said, every patient is different. So you need, some patients might take half an hour, 45 minutes. Some patients within 5 minutes I'll finish. But I have said that this is my thing, and within this time span I have to finish, let's say, 30 patients. But you're right, we cannot do that in a government setup because they don't have the right to choose. On a given OPD day, because I've worked in a government hospital, you can have hundreds of patients or you can have just 20 to 30 patients. Generally, it will be hundreds of them. So you will not even listen to the patient. Patient comes, you listen to the symptom, write the drug, send them off. You don't even educate them or tell them when to come back. I'm sure Ms. Jyoti must have experienced that. So there is a big need gap. See, one of the reasons is because, you see, in Western countries, everything is insurance driven and the state is covering your health policy. Unlike in India, it is totally private driven. I think the budget allocation for health is very less, 2 to 3%. So the infrastructure in government hospital is very poor. Coming to the treatment as well, which I wanted to comment, there is a huge difference in the treatment you might get in a private versus a government. I'll tell you why. Because, for example, in my practice, if a patient has gone to a government hospital, they can only write something called human insulin, which is cheap, which can be available in that formulary. I know that the pharmacokinetics dynamics of that particular insulin is not good. I will never be able to achieve control. When they come to me, I give them the best and the latest insulin and best and the latest OHAs, the oral hypoglycemic agents, which is not available in a government setup because it's expensive. Why? Because there's something called loss of exclusivity or patency protection. During that period, that company will sell it at a particular premium. That premium, the government can never make it available. So in her case, maybe the antiretroviral therapy, the latest ones, the government patients can never avail. So definitely there will be, a need gap in the kind of treatment outcomes. I can use an insulin pump. I can use a lot of monitors, for monitoring blood sugar. So that can be done only in a private setup where patient has to pay out of pocket. Insurances are not covering that. Same drugs abroad they can use it, even if it is several thousand rupees, because it is covered by insurance. So they can get access to the best treatment. But yeah, definitely in private practice, if you see less patients, you have a good team. Team is very important. Educating, informing the patient, you can have better outcomes. Government setups, you can never expect that.
Can I make a point to it? Because I do understand the limitations of working in a government setup where we know the workload is actually honestly very high. But at the same time, I always tell that if you will look at the problem alone and you say that problems are problems and cannot be resolved, then I think we really need to reconsider our thought process, because ultimately you have to find out solutions to the problem. So the solutions that I suggest when you have say 100 patients, because I did a number of studies in government setup to see how many patients are the doctors seeing on an average in Delhi, in huge hospital. So we got to see an average doctor sees around 70 to 80 patients in an OPD. So if I calculate the number of minutes one is able to give per patient, it comes down to 2 to 3 minutes, not more than that. So as very rightly said by you that they are not even able to talk to the patient, just take the history and write sometimes even they don't even take proper history. I think that's where we tend to make mistake. So there what I would suggest is, being a clinician, you get to see that this patient is a fresh case, does not require very detailed working. And then there are cases that they require, you know, larger working. So that means, I don't know how many of you have heard of Pareto's law? No. Have you heard of it? Yeah. Pareto was an economist. He gave this law that 80% of the economy is in the hands of 20% of people. Yeah. So later on it was found that this law is applicable to many other spheres of life. And if you see even in your practice with your patients, 70 to 80% of the patient would be such who would actually not require very detailed talking or working. You can actually diagnose them. For example, if a patient comes with Dr. Sahab bar peshab aa raha hai, jalan ho rahi hai, so you would know it's a fresh case of UTI, and you'll ask kitni bar pehle kabhi hua, nahi pehli baar hi hua. First case hai to usme you will write medicines and you will not spend more than maybe 2 minutes that patient. But in case if you get to see a patient who requires detailed working, I can't say I don't have time, so I will not work with you. That means these 20 to 30% of the patient require my attention. I have to make some arrangement in my setup so that I don't let them go unattended. Maybe I'll have to call them in the afternoon. Maybe I have to ask them to wait. Maybe I will have to ask them to come again in the morning when comparatively, or if the OPD is slow, is kind of comparatively lighter, or any day when you think you have time. But we got to design some mechanism where we don't neglect these patients, because these patients keep moving from one hospital to another. They keep taking treatment, but sometimes even they are not even diagnosed properly. That's one way I always say. Second, as you said that we haven't done any study to check like what is the time the patient wants, and the research also is not done in the area of yes, who will bail the cat? Who will bail the cat? Who will, I mean, I don't think doctors very honestly come forward for the research where we say them we want to see your communication skills and your ability to build rapport. Very rarely anybody comes forward and you tell them that this is what we want to study. They are beyond that kind of this thing. Of course, a time will come when even this will become part and parcel of the system, but right now nobody wants to. Third point with which I will end and answer your question. Fortunately, patients coming to government setup, they are not very demanding in terms of time and explanation. Most of them are satisfied if your behavior with them is good and if you have been able to diagnose and give them treatment. Because they don't expect कि मुझे बिठाकर बात करेंगे, मुझे पूछेंगे अच्छा आप कैसे हैं, आपने पिछली दवाई खाई, are you feeling better, are you improving, आपने सुबह क्या खाया था. In private practice we do it because we know patient wants all this. The kind of clientele we are getting in government setup, they are mostly poor people. So what they want कि डॉक्टर अच्छे से बात कर ले, देख ले, ठीक से मुझे पूछ लें, दवाई दे दे, बस इतना काफ़ी है. So we can take advantage of it. We may not give lot of time, but if our behavior in those 2-3 minutes is good, most of the patient will go very satisfied with the behavior. I think you will agree with me on that. Thank you.
I think very important point raised by Dr. Indu. One aspect of service quality perceptions is that I manage the expectation itself. So when you go to a railway station, you don't expect the train to come on exact time, is it not? So if it is 10 minutes late, it's fine, it's on time.
It's okay.
So you manage the expectation itself, and in government setups, you don't expect that I will get to see the doctor within 2 minutes. You go there with an expectation, आधा घंटा 1 घंटा लगेगा, and that is very important aspect of service quality management. And I think doctors have slight advantage in that, even in private setup. So very important point. And yeah.
So thank you so much for the great presentation to the panel. I just wanted to make more of a comment than a question. I worked a little bit in sub-Saharan Africa with HIV. And one of the models that they had, because the ratio of patients to providers was very small. So they had, and you might have this in India as well, is a differentiated care model, where not every patient that comes in actually has to be seen by a clinician. They go through a triage. The triage nurse will kind of do a preliminary assessment, and then they'll recommend you need to see a clinician. Can you just get away with seeing a pharmacist and just getting your medication? Can you go and just see a nurse? And so that way you're reducing the burden on the trained clinician, and the trained clinician is then seeing more severe patients, and they have the time to spend for that deliberation. So I just wanted to kind of throw that out as a model that I've seen used successfully, at least in other countries.
I think Dr. Balaji's presentation also, the importance of staff being knowledgeable and empathetic, that also frees a lot of time for Dr. Balaji. And one more important structural changes which Dr. Indu was also talking about, that I want to give special attention to these people because they have complicated history. So when I was in Baroda Medical College, we have a separate time, afternoon, for epilepsy and nephrology. So we don't see them in our normal OPD. So when they come, we tell them, you come on Thursday afternoon, and 2 hours are dedicated for epilepsy because their history is too complicated too, because drugs will change, the type will change, and somebody will have multiple disorders, etc. Same thing with nephrotic syndrome. So we used to have 2 different OPDs for those patients. So there are baby steps, some steps can be taken to at least provide sufficient attention whenever it is required, and the doctorization, as she has pointed out. Okay. Any other questions? Yes, sir.
So it has been a long standing kind of tussle among doctor organizations, doctor lobbies, IIMA, etc., that who has the right to prescribe medicine. Okay. So in a sense, that lack of doctors cannot be an ideal model. When we are talking about this triage system in Africa, it is kind of collecting from nothing sort of a method, and doctor organizations in India have been very loath to having that pushed in the sense that then what you have is a kind of institutionalization of two-tier healthcare. Some will see doctors, some will not see doctors. There is good evidence that this is under the garb of reducing pressure on doctors, of you have a permanent solution that some people will never get to see doctors. Okay, typically poor people. Okay, then it kind of flows along many ways. Just to give you some recent examples, so there was this in multiple states, especially in Bangla, kind of. So as you said, in a way, a form of that is common diseases happen commonly. So probably 90% of healthcare would be a few diseases in a way, typically. So why not train people who know just about these diseases, etc., etc. These initiatives typically have fallen flat at that exact point whether they have the right to prescribe or not. Okay, so we have had earlier in the early 80s couple of batches of such kind of fast-track medical professionals for few diseases, but most cases being produced. They have really gone nowhere. Those batches, essentially these are wasted years in those people's lives, including nurses. They don't have right to prescribe, etc., etc., including what is rampant in a both crossway. For example, lots of MBBS, they prescribe, let's say, Live 52, okay, or various kinds of carmozyme, right? They do not have the right to prescribe it because they have no training in the pharmacokinetics and pharmacodynamics of these chemicals, which are basically herbal chemicals. So you are doing it not on evidence, but based on hearsay, which is typically advertisement. Again, in the same way, when BAMS or BHMS or BUMS, these are all degrees, homeopathy, Ayurveda, Unani, when they prescribe, again, what are quote-unquote allopathic medicines, the same problem. If you are not studying what this drug is about, just because it is a medicine, and if you do not know why and how it is a medicine, then that right cannot be given. This has been a long-standing kind of debate on territoriality, if you will.
That patients are treated, their blood sugar is almost normal. They may not be consulting doctor every month because as we already discussed, Google and so much of information around. And most of the families, senior citizens, they already have this suffering from diabetes, and the family already knows about a lot of information. So they get the treatment, they continue the treatment. I would like to know how frequently a diabetic patient should consult a doctor in case the blood sugar level is not very high above the normal level. And some people do self-medication also. So what is the harm in doing that? And mainly how frequently a patient should consult a doctor. And are there any chances that the patient is completely cured of diabetes, or is it a lifetime treatment? Anything on this? Thank you.
Actually, it's more of a technical question. Yeah, but it's good since you've asked this question, because now diabetes is one of the most prevalent, if I may say, non-communicable disease. It has a significant burden, there's a lot of healthcare cost and all. So you first of all asked me about patients who develop diabetes at a young age. Yes, I am getting to see a lot of patients who are getting diabetes. Now when I'm talking about this is called type 2 diabetes, which was otherwise known as a disease which occurs after 40, 45, 50. But nowadays, early onset type 2 has become very common. It is mainly because of lifestyle changes, urbanization, poor dietary patterns, sedentary lifestyle, increased stress levels. If you see in metro cities, people are very stressed. They don't have the time. They have very short timelines, deadlines within which they have to work. Other pressures are there. Sleep has come down. That is another risk factor for diabetes or hypertension, cholesterol, heart disease and all. Other type of diabetes that we see is the juvenile type, that is type 1. That also comes in a younger age. For that, they have to be on insulin. In fact, that is a much bigger stigma where we need a lot of psychologists to counsel them, the family, the schools where they study. Many a times what happens, I have had a young child, 10-year-old, he has to take insulin before lunch. Now, the other children around him, they think, okay, this is something, he has a disease, I should not be in contact with him. Or they might have a hypoglycemic episode where the child is feeling giddy and the teacher doesn't know about this thing. He wants to eat something the teacher is not allowing. So education at multiple levels is very, very important for a very young person on insulin type 1. Type 2 being a lifestyle disease, many a times with youngsters what happens is once they get good treatment, sometimes they don't follow up. They feel their sugars are under control. Maybe after 1 year, 2 years they'll come, or if they develop some complication. Because diabetes is a very silent disease. It won't give you any symptoms unless your HbA1c is going about 10, 12. Then you have other symptoms like weight loss, urination, thirst and all. Ideally, every diabetic should follow up every 3 months, ideally. Because that HbA1c test we do every 3 months. And the complications of diabetes should be checked once a year. So what we call retinopathy, nephropathy, neuropathy, those are the microvascular complication what we say. And then macrovascular, that's large vessel disease. So stroke, cardiovascular disease, peripheral. So that also once in 6 months or once a year, depending on whether the patient has it or not. If he already has something, we have to check it more periodically. But from a sugar perspective, every 3 months we should get that HbA1c and ensure it is around 7 or less than 7%.
Okay. Hello. Yeah, hi. Thank you everyone. It's wonderful presentation by all the panel. My question is like, we talked about this, we are having a lot of issues regarding the structural and again a dehumanization and de-individualization, and partly because like a kind of a trust deficit on this human touch between the patient and the doctor relationship sort of thing. So what I think is that, can we think like it's partly because of that, nowadays we see that a lot of process driven activities is happening in the organization. So a kind of NABH accreditation, JCI sort of thing. So we are more focusing on structure, more focusing on documentation. So a kind of a close monitoring sort of thing is happening over. So in that sense, does this anyway make a kind of a reason towards decreasing the kind of a human touch sort of thing? Your comments, please.
I think whenever we go for accreditation with a shallow understanding of the purpose of accreditation, then I think these kind of things do happen when we over focus on documentation or at least creating some evidence of what we are doing, but in spirit we are not doing it. See, the purpose of NABH accreditation or JCI accreditation is that we want to bring in quality to the healthcare delivery system. Where what we want to do is that we start having some protocols for every work that we are doing and then following those protocols. But unfortunately, that's where we fail. We have the protocols on documents, but they are not applied in spirit. It's more of a probably lack of understanding at the team level as well as at the team leader level, where they don't realize the importance of that human touch, empathy, creating good work environment. I think that's something that we are lacking in some of the places, so that there we get to hear these kind of problems more. Yeah.
I think I would like to borrow a word from Dr. Balaji. He had written a word called mindfulness. So when that is what she says, if it is applied in spirit, then actually it can enhance the perception
outcome
of
and definitely, yeah.
So on behalf of all IIM Ahmedabad and CMHS, I would like to thank all the panelists once again for coming here and highlighting very important issues in doctor-patient communication. This session has been video recorded with your due permission, not written but oral, but we will prepare a concept note and share with you. You can add or delete whatever we have written on the basis of your deliberation, and then we will circulate amongst our CMHS stakeholders. Okay, thank you so much. And our gesture of token of love and appreciation from IIM Ahmedabad CMHS, Dr. Garga Chatterjee. मैडम आप दीजिए, आप लोग दीजिए. डॉक्टर गर्गा चैटर्जी सर. मैडम फोटोग्राफ हाँ यहाँ पे बीच में आ जाइए. अच्छा ठीक है. ज्योति बहन, हाँ, फॉर द सेक ऑफ डॉक्यूमेंटेशन. मैडम सर को एक बार फिर से दे दीजिए वापस लेके. Dr. Balaji and Dr. Indu Arneja. Thank you so much. Thank you so much.